I think I know everyone in the room, but for those that don't know me, my name is Jason. I'm one of the fourth-year residents. And today for Grand Rounds, my topic of choice is the perioperative considerations for the South Asian patient. So as this is a university talk, I just like to say I have no disclosures, sadly. And as we get started, I'll be using this term South Asian throughout this presentation. So what I'm referring to when I say this is I'm referring to a term that describes a heterogeneous population. So shown on the screen are the countries represented when I use the term South Asian. Now, what's important to know for a Canadian center is that according to the 2011 Canadian census, there are more than 1.6 million people of South Asian ethnicity living in Canada. And amongst the most populated or major Canadian centers, South Asians are consistently amongst the top 3 most populated visible minorities. Now, in terms of their dynamic growth, South Asian population is expected to double, if not triple, by the year 2031. And as such is one of the fastest growing ethnic minorities in Canada. So how I've chosen to approach this topic is a systems-based approach. And so throughout this presentation, I'll be going through this order of our considerations. So the first thing I'd like to do is talk about the cardiovascular disease in South Asians, and specifically coronary artery disease. Secondly, I'll talk about metabolic syndrome and its implications in the perioperative period, specifically related to South Asians. And the last component of this talk will revolve around the specific considerations around obstructive sleep apnea, renal injury, and the obstetrical considerations in the South Asian patient. So to get started, we'll talk about coronary artery disease and the cardiovascular considerations. Now shown here is an angiogram of a South Asian patient who presented for coronary artery bypass grafting. And when you look at this specific angiogram, many of you might say this is a one-off example of someone with severe coronary artery disease of South Asian origin. But the features of this angiogram are actually representative of what's known as South Asian heart disease, and the specific features I'll talk about here. Now, there's a couple of things about this that are a little bit different. The first thing is that South Asians develop coronary artery disease at younger ages. Now, a study by Youssef et al. Showed that patients of South Asian origin developed their first MI at about age 53. And this is younger compared to other regions of the world where the age is 59. Now, a specific subset of this is young patients who develop coronary artery disease, or patients under the age of 45. Now, the general incidence of this is about 1.2%, but in South Asians, the incidence is about 5 to 10%. Now, when South Asians develop an acute coronary syndrome, they present to hospital later during the course of their infarction, and this results in worsened morbidity. So a study done in Ontario found that the average time that a Canadian presents to hospital is approximately 3 hours after the symptom onset of coronary artery disease. But they found that this is about 4 hours in South Asians. And furthermore, when they followed these patients in hospital, they found that they had recurrent angina and subsequent readmission to hospital in excess compared to other Canadians. Now, another Canadian study that was published in the CMAJ in 2002 examined where these infarcts actually occur. And it was found that anterior infarctions are more common in South Asians. And when they measured the peak CK levels, they found that this was larger. There was a trend towards larger infarct size in South Asians. And lastly, the angiographic features of South Asian coronary artery disease have been examined in various studies. And there are a number of specific considerations that have emerged and trends that have emerged. Now, they have more significant LMA disease. They have more proximal lesions, diffuse disease, and smaller intraluminal diameters of the arteries that the stenotic lesions occur. And so when we see an angiogram like this isn't necessarily a one-off example of severe coronary artery disease, but rather a very typical example of what this looks like in a South Asian patient. Now, these features were compared against the features of Canadian coronary artery disease in this study. And while the findings of left main disease did not approach significance in this study, it has been shown in other studies that left main disease is more common in South Asians. Now, the degree of stenotic lesions is also higher in South Asians, and this is stenotic lesions greater than 70%. The number of vessels also affected approaches significance, And the patients presenting for their initial angiogram without coronary artery disease are fewer, and those with distal coronary artery disease is more. Now, similarly, another study looked at the number of disease segments, whether this be proximal or more distal segments. And what you can see here is the trend that Caucasians present with higher numbers of single segment disease. Whereas when you look at this trend in South Asians, there are more numbers of disease segments as patients present. Now, one of the theories to explain why coronary artery disease is so prevalent among South Asians has been that they have smaller coronary artery disease, and I alluded that they have smaller intraluminal diameters of the vessels affected. And this has been evaluated in a number of different studies. And the consensus out of all these studies is that yes, the absolute size of coronary arteries is smaller, but when this is referenced for body surface area and cardiac size, this is not smaller. And furthermore, another study looked at whether this is a factor that implicates CABG and revascularization, and they found that surgical time and cross-clamp time are no different in South Asians undergoing coronary artery bypass grafting as compared to other North Americans. Now, when I was doing this talk, I thought, what really, if there is such a high incidence of coronary artery disease and cardiovascular disease, are there any specific physiological traits that could explain this? And throughout my research, I did actually find that throughout, the levels of aortic anatomy and cardiac anatomy, there are specific differences in South Asians. At an atrial level, South Asians have smaller atrial size, and this has been indexed in this study, which actually published ethnic-specific ranges of echocardiographic measurements. They found that South Asians have anywhere between a 13 and 19% lower atrial size compared to Europeans. And when this was looked at amongst the morbidity and disease outcomes in South Asians, this is actually a protective effect against atrial fibrillation. And many of you guys are thinking, well, if this is protective against atrial fibrillation, how are we presenting this in a pathophysiologic consequence? Well, really, the incidence of cardiovascular disease and stroke is 1.5 to 2 times higher in South Asians. So even though they're protective against atrial fibrillation as seen by these studies, this doesn't mitigate their risk of subsequent stroke. At a ventricular level, there are also multiple changes. They have a lower LV mass, but many of you might think that this is protective against the development of ischemia, but they have an increased relative wall thickness and increased rates of concentric remodeling. And this is shown by this study, which was quite a large study that looked at the echocardiographic features of South Asians and compared them to other Europeans and African Caribbeans. And furthermore, this study looked at the function of the left ventricle in South Asians, and they found that there is a worsened systolic and worsened early diastolic functioning among South Asians. And what's very important to note among these studies that suggest this is that the patients they looked at were healthy patients. They weren't patients with cardiovascular disease or those admitted to hospital. These were patients, healthy patients, that they looked at these echo findings. So even amongst the general population, there are these trends towards worsened ventricular function. Similarly, there are changes in the conduction system. So this study looked at resting heart rates, heart rate variability, and baroreceptor sensitivity. They found a significant trend towards higher resting heart rates in South Asians, up to 10% higher, with an average resting heart rate of 64 in South Asians compared to 59 in Europeans. And while it didn't approach significance, they did find a trend towards worsened heart rate variability and baroreceptor reflex sensitivity. The authors go on to suggest, when looking at the data, that there is some degree of impaired autonomic function in South Asians with less vagal contribution to resting heart rates and increased sympathetic activity. And this could potentiate their risk of development of coronary artery disease and cardiovascular disease. And one thing that's been suggested and looked at significantly in this population is the arterial dynamics. Now, there are two trends that really emerge in the literature. One is that South Asians have stiffer central arteries, and this results in increased pulse wave propagation and increased dynamics of hypertension in this population. And lastly, that they have altered aortic waveform measurements. And I thought this was important for us because oftentimes when we see patients in a surgical context, this is often their first encounter with the healthcare system, and oftentimes one of their first presentations at which an arterial waveform may be even looked at. So here are several examples of these aortic waveform measurements. And essentially what they reflect is those on the first part of the curve reflect the excess ventricular work that is done in someone with an abnormal anatomy or physiology. And the dynamics on the right portions of the curve reflect the wave that's reflected back from the periphery. So stiffer arterial vessels and more hypertension, those dynamics get reflected back, and then these measurements are calculated. And what's very important to note is that of all the dynamics that I've listed here, they all relate to cardiovascular risk and have been shown to be predictive of cardiovascular risk. So that previous study actually looked at these dynamics in a large subset of patients and compared South Asians to Europeans. And not surprisingly, they found that all of these aortic waveform measurements are significantly worse, and this relates to cardiovascular risk. So now that I've shown that, that at some level there's a bit of physiologic or a significant amount of physiologic difference between South Asians and non-South Asians, when they present to us in a pre-admission type context, many of us would say that this would be important then to risk stratify them. Now, there are again differences in how South Asians are risk stratified for cardiovascular disease. Now, the first important thing to note is that South Asian ethnicity, independently of any other disease states or comorbidity, is predictive of cardiovascular disease. And when we look at traditional risk factors, things that we would typically assess for, this doesn't apply uniformly to South Asians. Things that have been shown to be more pathologic or more pathogenic are diabetes, hyperlipidemia, and metabolic syndrome. Now, they have roughly equivalent rates of hypertension, and things that have been shown to be less predictive are things like smoking and alcohol consumption. And this is particularly reflective of South Asian women who have very low rates of alcohol and smoking. And another study which showed that alcohol consumption is not predictive of development of acute MI in South Asians. So what it essentially says is that these things don't apply uniformly. And what's more is that when we look at the increased burden of cardiovascular disease amongst South Asians, this incompletely addresses that, as the rates of coronary artery disease are approximately 1.5 to 2 times greater compared to European populations, and this inadequately predicts that. Now, what's further more interesting about this is the timing of when these comorbidities develop. So this study looked at the timeline at which comorbidities related to coronary artery disease develop. And what's very alarming is it seems that at birth onwards, South Asians are more predisposed to developing coronary artery disease. So at birth, there's already increased levels of insulin and leptin, which predispose to diabetes. And by the time these patients are about 8 years old, we already see that the effects of metabolic syndrome are already developing. And this coincidentally is when when childhood obesity spikes in South Asians. And by the time these patients are about 18 to 25, they've already developed those changes within the central vasculature, resulting in stiffer central arteries and already deranged aortic waveforms. And by the time we would see them and think of them as first-time presenters of comorbidities, they've already developed this whole panel of comorbidities shown on the right. Now, how this relates to revascularization is that there are differences in outcomes of South Asians once they have addressed their coronary artery disease. In the available literature, there are 7 studies which look at the outcomes of South Asians compared to Caucasians and North Americans in regards to coronary artery bypass grafting. Now, when they looked at the long-term outcomes, there's similar, potentially improved outcomes in South Asians. And this is beyond the 1-year mark or potentially the 5 and 10-year mark. Now, what is different is the short-term outcomes. So there is a trend towards increased perioperative morbidity and in the short-term post-operative stay, and an increase in short-term mortality under 1 year and under 30 days. There are also specific subgroups that emerge in the literature, particularly South Asian women who are at increased risks of postoperative sepsis. And within the literature, there's studies that show that there's increased rates of recurrent MI and subsequent need for medical intervention after revascularization. So this study looked at those specific postoperative outcomes and looked at them in South Asian patients versus other Canadians. And this was a study that was done in Toronto in 2007. And the numbers there, you can see that there's 917 patients in either arm. This is actually a smaller sample of the total number of patients, which was just under 6,200 South Asians. And what they found was that there are a number of different outcomes that are worse in South Asians. Now, the first is that they have increased ventilatory times, increased length of stay, and increased postoperative stay. And within that time, they have worsened low cardiac output, they have increased recurrent MI, and increased rates of sternal wound infection. And similarly, when it comes to non-surgical revascularization, those same trends emerge, that similar or improved outcomes in terms of long-term outcomes and long-term mortality, but in the short term, they have increased morbidity, so increased risk of recurrent MIs and increased risk for repeat revascularization. Now, when I was thinking about all of these outcomes, I thought, we often see these patients within this period, either from an acute context, from patients coming back from CBICU, or after recently after their acute coronary syndrome, and we debate the risk of proceeding with surgery or not, or delaying elective or potentially elective surgery. And I thought, when these patients present, what would be the things that would really strike us the most? And this study was actually done in Edmonton by Dr. Kevin Bainey, and it showed that South Asians, after their index event of coronary artery disease, have worsened quality of life and worsened outcomes. And now what I'd like to really draw your attention to is that first point there, which was regards to physical limitation. Many of us would look at the risk of elective surgery based on this alone and looks at a patient's metabolic equivalence. And it seems that even in this context, South Asians do worse. So if I were to make a summary slide about the things we've learned about coronary artery disease and cardiovascular disease, it's that South Asians have more aggressive forms of coronary artery disease that develop at younger ages. What underlines this is not simply coronary artery diameter, but actually specific physiologic differences and worsened left ventricular function. And all of this is poorly predicted by our traditional panel of risk factors. And lastly, what we might think that after revascularization that these patients have improved outcomes and improved revascularization status at the 1-year mark. This is not true. So the next portion of this talk will focus on metabolic syndrome, diabetes in South Asians, and how this relates to the perioperative period in our practice. So this is metabolic syndrome. So essentially what it is a constellation of several comorbidities. And the most commonly used definition of this is in 2011, there was the National Cholesterol Education Program, and they published the mostly accepted definition of metabolic syndrome. And it's encompassing 3 out of the 5 of the following: central obesity, hypertriglyceridemia, low HDL, hypertension, and diabetes. And what's important to note about metabolic syndrome is really the sum is much worse than any of the parts. And when you look at definitions of metabolic syndrome, the criteria for diabetes and hypertension is not necessarily very significant and doesn't necessarily involve end organ damage. So really, what we might see is maybe that the silhouette on the right side, which is a patient that looks somewhat out of shape and has some mild comorbidities, but really this is all encompassing of these various features. Now, the pathophysiology of metabolic syndrome all relates around central obesity. And what it basically states is that in central obesity, there's these adipokines, which are hormones that are active, and this results in 2 separate spheres of effects. Now, the one sphere on the right side is the inflammatory component, which results in significant endothelial dysfunction and increased levels of circulating inflammatory mediators. And on the other side, we see that these adipokines are very endocrine hormonally active, and basically this results in insulin resistance and the comorbidities that are the components of metabolic syndrome. Now, when we think about metabolic syndrome in the patients that we would typically see South Asian immigrants who have this constellation of comorbidities. And this actually occurs at increased rates in South Asian immigrants. And the reason for this is what's called the thrifty gene hypothesis. And it basically relates to the fact that at one point in hunter-gatherer populations, the ability to store fats and to metabolize carbohydrates easily were advantageous. And that over time, as patients or as these populations go to become urbanites and then further on go on to become immigrants, that these things that were once advantageous actually turn out to be the mediators of a lot of comorbid and chronic conditions. And what seems to be the catalyst out of all of this is the easy availability of fats and carbohydrates. And that essentially turns those genes which were once advantageous into chronic disease. And this has been studied in South Asians and showing that essentially as you go from more rural areas to becoming an immigrant, all of these specific factors actually worsen. So when we see a patient that might present here for surgery, in terms of these comorbidities or these specific aspects of metabolic syndrome, these are all actually worse. And how this applies to South Asians is that they have an extremely high incidence of metabolic syndrome. And it's estimated that in immigrant populations, this number can reach up to 50%. Now, South Asians are subject and at risk of metabolic syndrome at lower BMIs and lower waist circumferences. And so when we typically look at the WHO definition for overweight and obese, which is BMIs greater than 25 and BMIs greater than 30 respectively, in 2004, the WHO actually suggested that these criteria be moved to BMIs of greater than 23 and greater than 25 in South Asians, and that they also have reduced waist circumference cutoffs as well. And similarly, it goes on to state that at lower BMIs, South Asians have increased proportions of body fat and central obesity. Now, all of this essentially relates to that second sphere, which shows that in South Asians there is increased circulatory mediators, and they live in even a healthy state and in a pro-inflammatory state, and that there's increased levels of circulating cytokines, higher CRPs, and there's increased fibrinogen and impaired fibrinolysis. Now, one of the first studies I ever found on South Asian health was actually an anesthetic study that was done in Toronto. And what this group did was they looked at the level of inflammation on cardiopulmonary bypass of South Asians undergoing cardiac surgery. And what they found was that the red bars here is that South Asians exhibit significantly higher rates of inflammation on cardiopulmonary bypass. And what they further on did is that they correlated this inflammation versus long-term or short-term outcomes in the post-operative stay. And not surprisingly, found that South Asians develop worsened post-operative outcomes and higher rates of sequential organ failure. And furthermore, how this relates is that metabolic syndrome has been well studied in an anesthetic context through various different reviews and studies. And even simply, metabolic syndrome affects anesthetic outcomes. This group found that within spinal anesthetics, there's increased rates of intraoperative hypotension and hypertension and total number of complications when it comes to patients having spinal anesthetics. Similarly, they found non-significant trends towards hypoxemia, bleeding, pain, and increased post-operative nausea and vomiting in patients who had metabolic syndrome compared to patients without. The same group went to look at a similar cohort of patients undergoing general anesthesia. And once again, they found a number of different factors in terms of outcomes. They found increased rates of intraoperative hypotension and hypertension. They found a trend towards increased risks of intraoperative bleeding and hypoxemia. And similarly, post-operatively, they found increased rates of pain and nausea and vomiting, and trends towards post-operative hypotension, bleeding, hypoxemia, and in a post-operative setting. And how this relates further on to perioperative outcomes is that metabolic syndrome affects nearly every physiologic system and nearly all forms of surgery adversely. So in terms of neurologic outcomes, they have patients with metabolic syndrome have increased rates of post-op cognitive dysfunction and increased rates of perioperative stroke. In carotid endarterectomy, they have increased rates of subsequent stroke, MI, and morbidity. When it comes to cardiac surgery, they have worsened outcomes with regards to that, accelerated progression of valvular heart disease, increased rates of post-op mediastinitis, and atrial fibrillation. In liver resection surgery, they have increased rates of mortality. In colorectal surgery, increased morbidity and length of stay. In urologic surgery, they have increased rates of failure from their procedure and post-operative complications. In spinal surgery, there's increased rates of life-threatening complications, procedure cost, length of stay, subsequent MI, and pulmonary complications. In total joint replacements, they have increased rates of post-operative complications, cardiac events, and length of stay. And in vascular surgery, they have increased rates of morbidity and increased rates of VTE post-operatively. Now, of all the components of metabolic syndrome, diabetes seems to be what's the most pathogenic in South Asians. So this study looked at the predictors of mortality subsequent to coronary artery bypass grafting. And not surprisingly, diabetes was found to be a predictive factor of mortality, but not necessarily in Caucasians. Now, the mechanism at which diabetes predisposes to cardiovascular harm is listed here. Now, it mainly revolves around what the myocardium utilizes as a substrate. Now, what this is a balance between glucose and free fatty acids. And in diabetes, this spectrum is adversely affected. So there's impaired glucose metabolism, and so there's increased utilization of free fatty acids. And this ultimately resolves in myocardial harm, and particularly in ischemia. And all of this is potentiated by our patients that are fasted, those who have had heparin, and those who are subjected to any form of stress, whether that be the surgical stress or any type of adrenergic surge. And collectively, this cascade actually impacts South Asians much worse than non-South Asians. So this study, which looked at left ventricular function, found that hyperglycemia worsens left ventricular function in South Asians alone. They looked at several different parameters of global functioning, which they used in the N-terminal pro-brain natriuretic peptide. And in terms of systolic and diastolic function, they looked at the early and late transmitral filling and the peak systolic flow respectively. And again, in patients that are just diabetic without specifically any form of disease state, all of these parameters were worsened in South Asians, which was represented by the white bars there. And all of these differences also persisted when accounting for left ventricular mass. And similarly, this study looked at stroke survivors and what the cerebrovascular dynamics were. And they looked at South Asians versus non-South Asians. And within this study, they actually found that looking at arterial stiffness, there are trends that emerge which show that South Asians post-stroke have worsened cerebral or central arterial hemodynamics. And similarly, within their relative index here, which is what they looked at as a surrogate parameter of endothelial function, that South Asians post-stroke do far worse. And what's important to note about these results here is that even South Asians that are at risk and haven't necessarily even had a stroke had worsened central arterial stiffness compared to non-South Asians. So in summary, when it comes to metabolic syndrome, this is a well-studied phenomenon within the perioperative setting. It has a high incidence of in South Asians, and within each of those components, diabetes seems to be what is the most pathogenic. So metabolic syndrome occurs at lower BMIs and is suggested to have altered criteria for diagnosis of metabolic syndrome. And diabetes results in a worsened cardiovascular profile, more so in South Asians compared to non-South Asians. So the next part of this talk, I'll talk about a few specific considerations, starting with obstructive sleep apnea. So the concept of studying sleep apnea with regards to ethnicity has really emerged since 2013, but there haven't been that many studies that have looked at obstructive sleep apnea in South Asians. But this one seems to have been the most quoted in the literature. Now, this was a study of 343 patients that were assessed in a bariatric clinic, primarily with the goals of managing obesity and subsequent complications and comorbidities, and with regards to evaluation for subsequent bariatric surgery. All of these patients received a sleep study, and the specific criteria and the specific markers of OSA were looked at in this population, and they found several trends. The first thing they found was that the overall prevalence of OSA in South Asians, as measured by an apnea-hypopnea index, is significantly worse. And when they looked at the severity of OSA, all of their parameters were, with the exception of mean O2 saturations, were far worse in South Asians. This is the number of apneic events per hour. This is the amount of time spent under a SAT of 90%. And this is their minimum O2 SAT that was reached. And when classifying their OSA per the number of apnea-hypopnea index score, they found that South Asians had worsened OSA. Now, when it comes to renal considerations and renal injury, there are again a number of specific considerations that emerge when looking at the literature. The first is that there's an increased prevalence of microalbuminuria and overt proteinuria in South Asians. Now, this often comes on our preoperative blood work, and really there's not much significance attached to it in terms of the perioperative implications of this. But what really this is an overall marker of circulatory disease, a prognostic indicator for end-stage renal disease and cardiovascular events. Not surprisingly, after the previous data, it's no surprise that South Asians have accelerated progression and worsened impact of diabetes on renal function. It's anticipated that, or it's estimated that there's about a threefold higher increase in plasma creatinine in South Asians compared to non-South Asians and those who have diabetes. And this is really positively impacted with adequate glycemic control. And patients of South Asian origin have worsened risk of post-transplant diabetes. And of all of these things, metabolic syndrome has been implicated in renal graft dysfunction and loss of renal graft dysfunction after transplant, after kidney transplant. Lastly, there's a high prevalence of end-stage renal disease among South Asians. Now, there have been several propositions as to why this has occurred and why this has been observed. And most of these revolve around higher rates of hypertension and diabetes within this context. Now, this study attempted to look at why this actually occurs in South Asians. And they looked at nitric oxide production, as well as several other indices of renal function, such as functional renal reserve that was listed on the left side of the table here, and the change in plasma renal flow and the excretion of nitrates and nitrites, essentially all reflective of how nitric oxide works in the kidney. And they found that this is defective in South Asians compared to Europeans. And what this goes to suggest is that circulatory disease again negatively impacts South Asians. And again, what's important to note is once these kidneys of South Asian patients are subjected to stress, this is they have a worsened rate of injury compared to non-South Asians. So in this study, which looked at South Asians who were admitted for heart failure, when you look at their admitting creatinine, this is not significantly different compared to non-South Asians. But on discharge, when you look at the creatinine of these patients leaving hospital, they are significantly different. This study, which looked at renal injury following cardiac surgery, though it didn't compare to a Caucasian control group, it did find that patients of South Asian ethnicity develop increased rates of AKI following cardiac surgery. And this is again worsened when it comes to or shown on multivariate analysis, which show that South Asians do have this compared to other ethnic groups as well. So if I were to make a summary slide about these considerations, it would be to say that South Asians who are obese have worsened OSA, that in the population at large, particularly those with diabetes, there is increased prevalence of renal markers of circulatory dysfunction, and that when South Asians are exposed to conditions of high stress, such as surgery and disease states such as CHF, they have an increased risk of AKI. And for the last portion of this talk, I'd like to talk about the obstetrical considerations of the South Asian patient. Now, there are a number of specific considerations. Now, the first thing is that South Asians have a shorter mean duration of pregnancy. This was found to be, on average, about 1 week shorter compared to Europeans. But when this is looked at in terms of rates of preterm labor, this is significantly worse. So South Asian patients are subjected to what's called the healthy immigrant effect or the immigrant paradox. And what this refers to is the fact that when immigrants move to a new country, they avail initially all of the health resources that are available to them. And initially they have an increase or an optimization of their health outcomes. But over time, this effect actually fades. And what is shown here is that preterm labor is that preterm labor in developing countries is a significant problem. And when South Asians initially come here, they have lower rates compared to what they would have if they hadn't immigrated. But over time, their rates of preterm labor actually approach what they would in their native country. There's higher rates of postpartum hemorrhage and severe perineal laceration in Asian patients compared to non-Asian patients. And lastly, they have an altered presentation of gestational diabetes mellitus. Now, when we typically anticipate someone who's diabetic with their insulin requirements, we expect a large for gestational age baby as a result of this. But in South Asians, it's actually the reverse. They have small for gestational age babies, and this is related to what's anticipated as called a fat thin phenomenon for these babies, which is that the babies are actually small, but they have increased proportion of fat, which again relates to that increased level of insulin and leptin at birth. And the last thing is that metabolic syndrome in the South Asian parturient worsens their gestational diabetes. Now, this study looked at the provision of labor analgesia and obstetrical anesthesia as varied by ethnicity. And there were several trends that emerged. And for our purposes, this is with epidural anesthesia, that this prolongs the second stage, more so in South Asians compared to Caucasian controls. And this effect is magnified not only in the multip, but in any patient receiving an epidural. Similarly, this study looked at operative delivery and unplanned operative delivery as stratified by ethnicity. So this was quite a large study which looked at South Asians and Southeast Asians compared to what they termed their Caucasian control, which was a population of white patients in Australia and New Zealand. And when they looked at each specific parameter, one thing which would be operative vaginal births, this was higher in South Asians. Intrapartum C-section was also significantly higher in South Asians. And the rates of planned cesarean section were far lower in South Asians compared to a Caucasian population in Australia and New Zealand. Now, this is the provision of anesthesia in labor has also been looked at in terms of ethnicity, and there are several large-scale studies in the U.S. that have looked at this. And why I've listed an asterisk here is that in these studies, which are several thousand patients, they don't specifically look at South Asians as a subgroup, and the reason for this, or Asians as a matter of fact, and the reason for this is low numbers compared to Hispanic patients, Black patients, and white patients. And so as a result, many of these studies have termed this Asian group as other or not included it in their analysis. But what they have looked at is the effect of being an ethnic minority on the provision of anesthesia in labor. And several trends have emerged. That there is a lower epidural rate compared to white patients or non-ethnic minorities. There's a higher rate of GA C-sections compared to those with a spinal or an epidural. And lastly, there's a trend towards a later placement of neuraxial anesthesia. And there have been several ideas as to what propagates this, and this is not specifically due to lower SES status or later presentation to hospital, but other cultural factors that potentially serve as a barrier towards asking for earlier placement of a labor epidural. So in summary, there are a number of different considerations for the obstetrical patient. One is that South Asians present in earlier labor and have higher rates of preterm delivery, and this is in fact worsened by the longer amount of time spent after immigration. They're prone to postpartum hemorrhage and perineal laceration. They have an exaggerated second stage delay with epidural catheter placement. And lastly, they're prone to operative vaginal delivery or an unplanned C-section. And when we look at the effects of being an ethnic minority, this is the most feared consequence for us, which is a GA section. So if I were to conclude and make several summary statements about what we've learned for South Asians with regards to a perioperative context, I would say the following things. When it comes to cardiovascular considerations, they have a unique profile of coronary artery disease. And so what I would essentially argue is that whether or not this is a statement or an argument for us to increase our intraoperative surveillance and monitoring of this event, and whether we should consider routine postoperative troponins on these patients. Next, there are specific physiologic differences that we should look at in terms of not only their preoperative evaluation, but their functioning as a whole, especially within the realm of cardiac surgery. Firstly is evaluation of these patients by ethnic-specific normal values and have some degree of suspicion for left ventricular dysfunction. When it comes to our preoperative evaluation of these patients, it's recommended in the literature that screening for risk factors of coronary artery disease occurs not only at earlier ages, but also in patients that do not necessarily present with symptoms or comorbidities, as the suspicion for coronary artery disease should be done on ethnicity alone. And now when we see these patients post-revascularization, it's to really look at their risk differently compared to other populations. Now the first thing is those presenting within that short-term period, 30 days to 1 year, where they have worsened morbidity and worsened mortality, and they have ongoing risk of these events during that time period. And whether or not non-cardiac surgery or delaying of potentially urgent or elective surgery within this period is warranted, again, should be considered. When we look at metabolic syndrome, it's important to remember that this does affect anesthetic outcomes and perioperative outcomes. That this applies significantly to South Asians, and once again begs the question if risk factors should be screened earlier or more seriously. And lastly, to remember that they have increased rates of inflammation on cardiopulmonary bypass. So in things like where this could be potentially disadvantageous, like things like lung transplant, where there's options to do this without, whether this in South Asians is a specific consideration or not. And lastly, it's to remember that they have worsened end organ effects of their diabetes. So it's anticipation of some degree of LV dysfunction and arterial stiffness in diabetic South Asians, and this actually ultimately affects their post-operative status. With regards to OSA, it's to have the same suspicion of OSA in obese patients, but to remember that in that one study, they did have worsened OSA, even compared to patients of a similar BMI. When regards to renal dysfunction, it's to look at microalbuminuria and to have an index of suspicion of cardiovascular dysfunction and circulatory dysfunction, and whether or not we can have any positive impact on their diabetic management if that's seen in our preoperative blood work. And lastly, we remember that in states of stress, whether that's admission to hospital, admission for CHF, or post-cardiac surgery, that these patients are prone to AKI. So whether or not we should be routinely using renal protective strategies in all of these patients for our surgery, again, should be potentially considered. For obstetrical patients, it's to anticipate obstetrical complications in South Asians, as they have increased rates of preterm delivery, postpartum hemorrhage, and perineal laceration. Again, they have exaggerated second stage delay with epidurals. And once again, the only thing I would mention here is that whether or not this should be included in our consent for these patients or not. And lastly is to anticipate operative delivery, anesthetic involvement, and unplanned C-section for these patients as well. So in summary, I hope I've shown you that there are specific considerations and specific physiologic differences in South Asians that really manifest for us in the perioperative period. So just as I conclude here, I'd just like to thank a few people. First thing, I'd like to thank Dr. Sarita Sidhu for helping mentoring me throughout this presentation. And just a little shout out to Dr. Ed Bishop, who mentored a lot of residents throughout their grand rounds and his involvement for that. And these are my references. There's a lot of them there. Thank you very much. And